Good evening, everyone, and welcome to the GHAPP MASLD Community Network. Please use this QR code to record your attendance for this meeting. And also visit the GHAPP MASLD Community Network to view Madrigal MASH disease state education and Madrigal Rezdiffra promotional program. Our topic this is comparing F3 and F4 fibrosis. So today I'll be comparing F3 and F4 fibrosis and reviewing. Let's see here. Oops. Sorry about that. To move this over. So I'll be going over case 6A and 6B, and we'll be reviewing NITs on these patients. Let me go over here. No way I could. There we go. Sorry about that. So I'm going to start all over. So today I'll be comparing F3 and F4 fibrosis. During this presentation, I'll be reviewing a single patient profile and analyze under two scenarios, which is 6A and 6B, with differing non-invasive test results. With case 6A, we'll present the management discussion of a patient's NIT profile, which indicates F3 fibrosis, and case 6B will revisit the same patient profile with a slightly different NIT findings. And the goal is to compare and contrast assessment and strategies and management strategies of both case 6A and 6B. The core objective of this comparison is to illustrate the critical importance of accurate fibrosis staging in liver disease and highlight why accurate staging is crucial for prognosis, risk, stratification, and management decisions, and the difference in care pathways and clinical implications that arise from varying fibrosis stages. So specifically comparing F3 and 6A is more into a more severe stage implied by the NITs in 6B. So our first case study is Sam, who's a 55-year-old male who's referred for mildly abnormal transaminase levels and an abdominal ultrasound with increased liver echogenicity. He also complains of fatigue. Medical history includes type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, and he does not have a history of alcohol use. On exam, he is obese. He has no stigmata of advanced liver disease and no hepatosplenomegaly. His medications include lisinopril, rosuvastatin, ezetimibe, and dapagliflozin. These are typical medications for patients with metabolic syndrome. And upon review of his vital signs, his vitals are pretty much unremarkable except for mildly elevated blood pressure. His BMI is 33. You reviewed his labs. His ALT and AST are mildly elevated. Alk-Phos is normal. His T-Billy is mildly elevated at 1.17 with platelets of 157,000. Hemoglobin A1C is 7.1%. Other labs are pretty much unremarkable. Hepatitis panel is negative and autoimmune workup is negative as well. The next step for this patient will be check in his fibrosis assessment. The first easiest fibrosis test, test that could be done is a FIB-4, which his FIB-4 is 3.1, which falls into the intermediate risk category. Then after getting a FIB-4, the next thing was to get a FibroScan. FibroScan came back as 11 kPa, which this patient falls in the severe, significant fibrosis F3, and the CAP score is 262, which is moderate steatosis. The ELF test came back as 9.9, which is also severe fibrosis, but not cirrhosis at 9.9. So is there any further testing you guys would like to perform on this test, on this patient? Yes.
I would like to perform. You want me to talk?
Sure.
A FibroScan?
Sure. Any other testing? So his test came back, all his FibroScan and ELF tests came back suggestive of F3 fibrosis. If he's one that kind of falls in between F3 and F4 and you're not exactly sure how to determine the difference, you could potentially get like an MR elastography. However, FibroScan and ELF score came back suggestive of severe fibrosis, but not cirrhosis. So you may not want to do any other tests if you're sure on that based on the the FibroScan score. So how would you treat this patient?
Rezdiffra.
Okay.
Diet and exercise with Rezdiffra. Oh, do we need to talk about that?
Yeah, if you want to, you can talk in there.
Who's on there?
Trisha's on there with us, and so is Wes.
Do we know whether or not his metabolic disease is well controlled?
Well, I mean, his hemoglobin A1C is 7.1%. So, you know, it's okay, but it's not the best. So treatment and management for this patient would include Resmetirom, which is the Rezdiffra, which I think Lauren mentioned earlier. Lifestyle modifications. These patients need to optimize their management of their metabolic symptoms such as hypertension, hyperlipidemia, and diabetes. His sleep apnea definitely needs to be treated to optimize his cardiovascular risk factor mitigation. And also consider use of GLP-1 for his diabetes management, which he already isn't on one. So that would be something to maybe do to manage that a little bit better. And in order to manage him, you also want to make sure that you can consider HCC surveillance on this patient, check an AFP, make sure he doesn't have any other weird stuff going on, liver lesions and that, and also check a NIT in 1 year, as well as monitoring his hemoglobin A1C to make sure that his diabetes management is optimized. So imagine now the same patient profile, but different NIT results. So the same history, the same physical exam, same medications. However, labs are like slightly different on this patient. So vital signs are the same, BMI of 33, his liver enzymes, the T-bill is a little bit elevated in this patient. It's 1.4. Platelet count is 128,000, which is lower than the first patient. So usually when you see platelets this low, that's kind of suggestive of more advanced liver disease. This patient probably has cirrhosis of the liver. Creatinine is also a little bit elevated at 1.3. Rest of his other labs are pretty much unremarkable. It's the same as a first patient profile. So the next thing to do with this patient is to do a fibrosis assessment in order to determine how we'll be managing him. His FIB-4 score came back as 3.1, which is about the same as our first patient. However, his FibroScan result came back as 21 kPa, which shows advanced fibrosis. He's in F4. He has F4 fibrosis. CAP score in this patient is 245, which basically is suggestive of no steatosis or mild steatosis. Typically, when you see a low CAP score and a high kPa, that's usually suggestive of like a burnout cirrhosis. So this patient's probably burned the fat out of his liver, and that's why his liver score is pretty low. And on ELF test, his test came back as 11.4. So that's also suggestive of cirrhosis of the liver. So is there any further testing you'd like to perform on this patient with F4 fibrosis? And how would you stage this patient? Anybody has any answers? Okay.
I would recommend an EGD to rule out, to screen for varices.
AFB, CBC, INR.
And how would you treat this patient and how would you monitor this patient? Okay. So Q6 months HCC screening, and I heard EGD to screen for varices, and those are, and based on the NITs that were performed, this patient has cirrhosis. So treatment of this patient will include diet and lifestyle modification. Dietary modification, preferably Mediterranean diet, is recommended in weight loss. You do want to monitor for HCC, so getting an MRI in this patient and maybe alternating every 6 months which imaging modality you'll be using to screen for varices. And then, as Wes said, screen for varices EGD and screen for HCCs through MRI or abdominal ultrasound. You can also consider a non-selective beta blocker in these patients with suspected esophageal varices as well. So patient A and B, we're comparing both of them here with similar FIB-4s, different ELF scores. The ELF on A is 9.9, the ELF score on patient B is 11.4. The kPa on patient A is 11, and the kPa on patient B is 21. So how do these patients compare in management and staging between F3 and F4? So I would say that the management is pretty similar in both patients, except that the patient in F3 qualifies for treatment for his MASH with Rezdiffra, but both of them will benefit from lifestyle modification. And they would also both benefit from maybe optimizing their management of their underlying metabolic disease. Staging between F3 and F4, which NITs do you typically use to differentiate between an F3 and F4 patient if they're indeterminate NITs? So you have a F3 that's kind of borderline, and then you have a F4. Which NITs would you use? I think an MR elastography is probably a good one because it's non-invasive. Now, if they're talking about an invasive test, that's when we would probably consider like doing a liver biopsy. But when it comes to NITs, I think maybe doing an ELF score, if we're not sure, MR elastography would help kind of determine if your patient falls into either F3 or F4 category. And when is HCC surveillance important?
When they're cirrhotic, or suspected cirrhotic.
So HCC surveillance is important when patients have advanced fibrosis such as cirrhosis or any other viruses. Some patients, if they have hepatitis B, and even if they're not cirrhotic and they have advanced fibrosis, those patients need to be screened regularly because they're also high risk for HCC. And that is the end of this presentation. Thank you guys so much for taking the time to join me. Do you have any questions?